Well, hello out there, my friends and colleagues. I am Dr. Arthur Jones, and I'm speaking to you from Bensalem, Pennsylvania. It is a beautiful day today. However, this week earlier, we had a lot of that smoke from Canada coming down, and it was nasty, but it's clearing up. Anyhow, our topic for today is pulmonary vascular disease. Now, we do spend most of our time managing diseases of the airways and also the alveoli. However, it's important that we understand pulmonary vascular disease as well, because we will be involved with managing these patients. Here's your objective for this lesson. When you finish the lesson, you'll be able to explain the etiologies, manifestations, diagnostic techniques, and current management strategies for pulmonary thromboembolism and pulmonary hypertension. We're going to start out with the most common problem with pulmonary vascular disease. It is pulmonary thromboembolism. Definitions. First, a thrombus is a stationary blood clot. Okay, it's stationary, it isn't moving. It is in the deep veins of the legs, usually the legs. However, there are other places thrombi can occur, as we'll see. On the other hand, an embolus is actually blockage of an artery by matter, such as a blood clot, and this is a thromboembolism. This is a very important condition. Look at the incidence. In the US, pulmonary embolism strikes 650,000 patients per year. It does have a high mortality. The mortality is greater than 15% for the first 3 months after diagnosis. In 25% of pulmonary embolus patients, the first sign is sudden death. That's rather a dramatic sign, is it not? PE is the third most common cause of death, and it is the leading cause of maternal death. Diagnosis of PE, which are missed, are up to more than 400,000 per year. In other words, 400,000 people get a pulmonary embolus and the diagnosis is missed. About 100,000 patients die who would have survived with the proper diagnosis and treatment. As you see then, recognition and diagnosis of the PE is critical. Autopsy find a much greater incidence of PE among patients' death than are diagnosed. So more people die from pulmonary embolus that are not diagnosed. PE among hospital patients is considered a public health crisis in the United Kingdom. So, what are the types of emboli? Remember, an embolus is something that is blocking an artery. The first major type is a thromboemboli. These are blood clots. Then there is fat. Causes a lipid embolus, a fatty embolus, and this occurs frequently when bones are broken, fractured bones, such as a fractured femur. With a fractured femur, the incidence of lipid embolus is very high. Can also have another type of embolus is an air embolus. Most commonly, this occurs with decompression illness. For instance, a diver comes up from the bottom too fast and gets an air embolus. It can also be produced by a parenteral injection, such as an intravenous injection with air. And you see that you actually see this on TV and on cop shows where the killers inject blood into patients to kill them. Other types of emboli, an amniotic embolus. The amniotic fluid gets into mom's circulation, and this is a significant cause of maternal death. Other types include a septic embolus. A septic embolus occurs in conjunction with thrombophlebitis and also intravenous drug abuse, which causes thrombophlebitis. Another source of embolism, foreign substances. This is primary cause associated with intravenous drug abuse because the drugs do have fillers. They're not pure, and some of the fillers are very likely to cause emboli, and this includes, one of these includes talc or talcum powder. Final source of embolus is worms, parasites, such as schistosomiasis, which we're not likely to see in this country because it occurs in mostly in the Orient. So if you do see a patient with an embolus with schistosomiasis, they have been traveling somewhere. Okay, so where do emboli occur? First, in the brain. A clot occurs in the brain, and this causes a cerebrovascular accident, CVA, also known as a stroke. Another site for embolism is in the joints, and this is what causes the pain in sickle cell crisis. Yet another one is in the embolus can occur in the pulmonary arteries, and this is a pulmonary thromboembolism, which is the focus, the main focus of our discussion. So what are the risk factors for pulmonary embolism? First, there can be a high risk associated with an inherited predisposition, which causes thrombophilia, or the likelihood of developing thrombi, then which occur as emboli. This is primarily associated with younger patients, and it is associated with family members who have a history of pulmonary embolism. Another risk factor, DVT, deep venous thrombi. DVT is caused by, first, stasis, immobility. If the person does not move around, they do not increase, they do not they get poor venous return. So the blood pools in the veins, especially in the legs, and thrombi form. It can also be associated with surgery as well as trauma. Another risk factor for pulmonary embolism is malignancy, cancer. Of course, there are many more risk factors. Obesity is one, and obesity may be associated also with the immobility, not moving around. However, it can be an independent risk factor. Another risk factor is myocardial infarction, MI, pulmonary disease, especially among smokers. Polycythemia is yet another risk factor. Patients with excessive red blood cells tend to develop thrombi and then emboli. Another risk factor, pregnancy. Pregnancy because it causes pooling of the venous blood in the legs, which causes thrombi, then emboli. So pregnant women need to move around a lot. And yet another risk factor is trauma. and also vascular catheters. So let's look at the pathophysiology of pulmonary embolism. What happens? What does this do? How does it come about? Okay, first, we'll talk about perfusion of the lungs. There are two separate systems that perfuse the lung. First is the pulmonary circulation. The pulmonary circulation perfuses from the pulmonary arteries clear to the alveolar capillaries. And they also perfuse the alveoli, and this is where gas exchange occurs. So the pulmonary arteries are necessary for gas exchange. And you see here a picture of the pulmonary circulation. And then there is the bronchial circulation, which is equally important. The bronchial circulation is what perfuses the thoracic aorta down to the terminal bronchioles. So it perfuses the esophagus, the trachea, the visceral pleura, and the airways to the terminal bronchioles. So it is a bronchial circulation that keeps our airways alive. And this is a picture of the bronchial circulation. You see, it perfuses the airways. Importantly, the bronchial and pulmonary circulations are not completely, they do communicate through anastomoses. There are anastomoses between the pulmonary and bronchial circulations, and these are very important. The bronchioles to the pulmonary capillary beds, the bronchial circulation increases flow through these anastomoses to compensate for pulmonary embolism. So in the event of the pulmonary circulation being compromised to an area, the bronchial circulation will provide some compensation for that embolus. And this is a picture that shows the anastomoses between the pulmonary and bronchial circulations. This is very important. This is a section of the lung that shows a pulmonary infarction. A pulmonary infarction results from an embolism of a medium-sized pulmonary artery, and compensatory bronchial circulation then causes reperfusion injury. Reperfusion injury is very important. This also produces a hemorrhage. So this is a typical chest radiograph of a pulmonary infarction. That wedge-shaped shadow that you see on the lung is an infarct. Yep, that's it. So how do thrombi develop? Remember, it all has to start with thrombi. Blood clots in the deep vein is where thrombi develop. These can be in the calf, the thigh, the pelvis, and a thrombi that develop in the pelvis produce emboli that are frequently fatal. The same is true with blood clots with clots that form in the axillary and subclavian veins, or the subclavian veins, these also produce emboli that are frequently fatal, simply because they're going to be larger clots. The larger the vein, the larger the larger it is that the clot will be large. Also, clotting is predisposed by, first, hemostasis. Now, that is clotting immobility, hemostasis. The blood isn't moving. It is predisposed by a coagulopathy, where the blood tends to coagulate more frequently. Clots breaks off, then flows to the lung. Now we'll see a video of deep venous thrombosis and pulmonary embolism. Now that loaded up quickly, good. We're looking at the formation of a thrombus in the vein. Here the thrombus is in the circulation. From the vein, it flows through the heart, then to the lung. And we have a pulmonary embolus from a deep venous thrombosis. That's a pretty good show. So the pathophysiology, the hemodynamics, the severity depends on the size of the embolus. The larger the embolus, the worse the damage. The pathophysiology includes physical obstruction of the artery. It also, when the embolus forms, we get a release of vasoconstrictors. Then we get hypoxemia of the distal lung, which also causes vasoconstriction. So with a PE, we develop acute pulmonary hypertension. Pressure on the right side, on the right to the right ventricle is very high, or resistance of flow to the right ventricle. The hemodynamics, we get acute pulmonary hypertension, as I just mentioned. This increases the right ventricular afterload, which leads to ventricular dilatation. The ventricle gets larger. Interseptal bulging to the left. Because of the high pressure on the right, the ventricular septum bulges to the left, and this causes left ventricular impairment. A right ventricular infarction can occur, and with the infarction of the right ventricle, there is release of troponin and BNT, brain natriuretic peptide. The pathophysiology includes changes in gas exchange of course, because we have non-perfused lung tissue. If the lung is not perfused, we get an increase in the ventilation perfusion ratio. These alveoli that are ventilated without being perfused are dead space units. So blood is directed to other units away from the embolized portion, and this decreases their VQ ratio, leading to a physiologic shunt from those units. So this leads to overall mixed ventilation perfusion defects. We have dead space units and we have shunting units. We can also get alveolar hemorrhage and atelectasis, and this will contribute also to hypoxemia. Importantly, if the patient has a patent foramina valley, which is also an atrial septal defect, then there will be a right to left shunt worsening the hypoxemia. It's important, and I've seen this too many times, where a patient would be severely hypoxemic, and people initially just be scratching their heads. What the hell is going on? And the patient dies, and the only thing it could have been was a pulmonary embolus. Sometimes a very large one is called a saddle embolus. Okay, the effects on gas exchange. First, carbon dioxide. With pulmonary embolus, we get tachypnea, and the tachypnea causes arterial hypocapnia. With the alveolar dead space, we get alveolar hypocapnia and an increase in the alveolar to exhaled carbon dioxide. And this is an important, very important factor. If the patient should have hypercapnia, if they have an elevated PCO2, that means either that this is a massive embolus, that the dead space is tremendous, or that there is a comorbidity such as the patient also has, in addition to the PE, that also has something like emphysema. So when a patient has a PE, what do we see? What are the manifestations of a pulmonary embolus? Many symptoms. First and foremost, the patient will be anxious. They will be scared spitless. Notice I said spit. They will be very frightened. They will have chest pain. There will be chest wall tenderness, and this is an important sign. The patient will have syncope, shortness of breath, back pain, and there will be isolated wheezing. The hypoxemia to that area of the lung causes bronchoconstriction, and this causes the isolated wheezing. Physical signs include tachypnea, new onset of wheezes. Okay, the patient has no asthma, they have no COPD, but they are wheezing, and this is a sign that could be pulmonary embolism. There may be crackles on auscultation, and this is usually a sign of an infarction. There will be tachycardia, fever, sweating, diaphoresis, cyanosis may be present, hemoptysis may be present, and the patient may have signs of thrombophlebitis. And one way to determine if, for instance, if the calf is affected, if the thrombus is occurring in the calf, there's a sign called the Homan sign, where the physician or whoever will take the patient's foot, the bottom of the foot, and elevate it toward the head. And if that causes the pain, then there's likely thrombophlebitis. If the pulmonary embolus is massive, there will be dyspnea for sure, cyanosis, an altered mental state, cardiogenic shock, and possibly cardiac arrest, possibly sudden death. The chest X-ray might be normal. However, we still do the chest X-ray. What we have to do is rule out everything else to be sure that we have a pulmonary embolus here. So it is used to rule out alternative diagnoses. We may see reduced distal vascular markings distal to the embolus. dilated pulmonary arteries, atelectasis. Again, this is common with an infarction. The web-shaped density on the chest also shows an infarction, as we've seen earlier, and there may be a pleural effusion in about a third of pulmonary embolus patients. This pulmonary infusion is likely to be small, unilateral just in one area, and is also likely to loculate. If it loculates, it means if you reposition the patient, the effusion will not follow gravity. It remains exactly in the same place. The ECG may be unchanged from baseline. However, we still want an ECG to rule out alternatives. It could be a heart attack, an MI, as opposed to PE. So let's rule out MI. Most common with the pulmonary embolus on the ECG, we see sinus tachycardia, right axis deviation, and possibly a right bundle branch block. The blood gases are not specific for pulmonary embolus. There is most likely to be hypocapnia with mild to severe hypoxemia. Severe hypoxemia will occur if the patient has a patent foraminal valley, or, again, same thing with an adult, an atrial septal defect. This hypoxemia will worsen if we have a push the ventilator, if the patient is a ventilator, and we apply PEEP. End-tidal CO2 and arterial blood gases are used to measure the dead space to tidal volume ratio. This is a very easy task to do. It's very easy to accomplish, and it is very specific to pulmonary embolus. So, diagnosis of pulmonary embolus. The most important thing to look at here, we're trying to rule in or rule out pulmonary embolus. There is a risk stratification to select the treatment that's going to be used. So ruling in or ruling out, we get a risk to benefit for any drugs or interventions, and also the risk stratification is used to avoid costly procedures such as imaging. The basis for diagnosis of PE. First, patient history. Do they have a history of thrombophlebitis? Do they have the history of family history of PE or whatever? The history, the entire history. Then the basis also include the physical findings. What do we see on the patient's physical exam? Laboratory tests, and finally, also imaging. These are how we arrive at diagnosis. There is a clinical probability score. This is known as the Wells score. The parameters of the Wells score include a clinically suspected deep venous thrombosis. Also, that an alternative diagnosis is less likely than PE, the presence of tachycardia, and also immobilization or surgery in the previous 4 weeks. Also, other factor parameters for the Wells score include history of DVT, the patient's actually had it, or PE, hemoptysis, malignancy, with palliative treatment within 6 months. Interpretation of the Wells score, the traditional interpretation, score greater than 6, it yields a high risk for pulmonary embolus. 2 to 6, a moderate risk, A score less than 2, a low risk. But there is an alternative interpretation, and that is a score of greater than 4 means that a PE is likely. And this means we should do diagnostic image to confirm the diagnosis. A score of 4 or less means that a PE is unlikely, and what we need to do is do other studies to rule out PE, such as a lab study of the D dimer, and we'll get back to that. Actually, we'll get to it right now. The D dimer is a substance that is formed by lysis of fibrin. Lysis, by breaking down of a clot. If the D dimer is high, that means lots of clots are broken down. The D dimer is normally increased by aging, inflammation, malignancy, and also by an embolus. Importantly, the D dimer, please remember this, the D dimer has a negative predictive value. A negative predictive value is very important, combined with the well score. So if the patient does not have a high D dimer, and they also have a low well score, then these two together produce a negative predictive value. It means that we can avoid doing a bunch of expensive stuff to treat or further diagnose the PE. There are other potential markers for PE, but they need additional studies. These include the C-reactive protein and a substance known as myeloperoxidase. Other studies that are done include the troponin 1. And the troponin is primarily used as a prognostic indicator. In other words, how bad is it going to get? Troponin is a marker for myocardial injury. So again, remember we talked about the possibility of a right ventricular infarction. Here we go, troponin will be elevated. An elevation of the troponin suggests right ventricular overload. Troponin peaks 4 hours after suspected PE, and it may predict adverse outcomes for the PE. It also, if the troponin is elevated, it suggests that we may select aggressive treatments. BNP, brain natriuretic protein, is also a prognostic marker. If it is elevated, it will be elevated with right ventricular dysfunction, and elevation of the BNP is proportional to the severity of the embolism. So the BNP can tell us how bad it is. Pulmonary test, dead space measurement. I mentioned this earlier. Pulmonary embolus includes increases alveolar dead space, therefore the VD to VT ratio. The measurement, all we got to do to measure the VD to VT ratio is measure the end-tidal CO2 and the arterial PCO2 combined with a negative D dimer. The VD to VT ratio has a strong negative predictive value. However, research is needed to standardize the techniques and the parameters of using VD to VT for PE evaluation. This is good stuff, guys. Imaging includes, we've already talked about the chest radiograph. Let's go to more advanced imaging. A CAT scan, computed tomographic pulmonary computed tomographic pulmonary angiography in the helical or spiral. It's called helical or spiral. It agrees with a VQ scan for exclusion. So it's cheaper than a VQ scan, easier to do. it will detect a PE that's not found by a VQ scan. This is useful in detecting alternative diagnoses. Also, to rule out, you can rule out or rule in PE. An MRI has a similar accuracy to CT scanning. It also can be used to detect alternative diagnoses. And advantages of the MRI is that there is no ionizing radiation. It is safer for pregnant patients, especially if they're females. The technology for using MRI is advancing tremendously. The criterion standard for PE always has been the pulmonary angiograph. However, it does have adverse effects. It is not easy to do. The patient has to be moved around. Cannot be done in the sickest patients. Also, pulmonary angiogram is very expensive to do. But you see here, it will actually visualize. You actually visualize the embolism. Ventilation VQ scan is an old test. It formerly was the usual test for pulmonary embolism. If it is normal, it does exclude PE. A significant number of abnormal scans do not have PE, so it isn't that specific. A high probability scans confirms pulmonary embolism. And this is what VQ scan looks like. Well, now we're getting to modern times here, lung ultrasound. Lung ultrasound is valuable in detecting deep venous thrombosis. If the ultrasound shows, if the other signs suggest pulmonary embolus, and the ultrasound suggests deep venous thrombosis, then the positive test will be evidence for a pulmonary embolism. A negative result for the ultrasound suggests a decreased risk for recurrence of PE. Ultrasound is great. The equipment is much less expensive. There is no ionizing radiation, and it can be done at the bedside. And this is a lung ultrasound that shows a pulmonary embolus. Another one that can be done is the echocardiograph. It is not a routine test for PE. However, it may visualize central emboli, and it also can identify cardiac dysfunction and alternative causes of hemodynamic compromise. An echo will detect shunting through a patent foramen ovale, or again, atrial septal defect. So that's how we find out what we got. How do we manage it, and how do we prevent it? Prevention is more important than management. It's just important and much cheaper. Okay, respiratory care to manage. First, all the PE patients will receive oxygen. If they're ventilated, it's important to know that the application of PEEP may open the foramen ovale because it will increase pulmonary vascular resistance. End-tidal CO2 is particularly useful to observe for changes in the alveolar to exhaled CO2. Okay, anticoagulants are universally given. Anticoagulants reduce the risk of additional clots. However, and they do slow clot progression. However, anticoagulants do not dissolve clots. Usually, what's administered is low molecular weight heparin, known as first Lovenox, Normaflow, and Fragment. 2, 3 separate preparations of low molecular weight heparin. Then there are also thrombolytics. Thrombolytics actually dissolve the clots, and thrombolytics must be administered for a massive pulmonary embolism, shown by clinical ventricular dysfunction, hypotension, and severe hypoxemia. Thrombolytics are controversial for submassive pulmonary embolism. Note, they may be administered, may not be administered. It'll depend on really on the doc or on the institution. Okay, they are considered for all patients with the pulmonary embolism and who do not have contraindications. Contraindications. And the contraindications of thrombolytics would include a previous hemorrhagic stroke at any time. It also would be contraindicated in the presence of active internal bleeding, suspected aortic dissection, and also in acute pericarditis. The thrombolytics will decrease the mortality and the morbidity and recurrence of the pulmonary embolus, thromboembolus. So what thrombolytics are used? Currently, what is used is TPA, tissue plasminogen activators, and these include these preparations: alteplase, retaplase, tenecteplase. Other older agents among the thrombolytics include streptokinase and urokinase. There are also invasive interventions to manage pulmonary embolism, and these include percutaneous methods, a catheter-directed thrombolysis. In other words, they go in with the catheter and break up the clot. Another percutaneous method that can be used for PE is actual embolectomy. A pulmonary endarterectomy can also be used if the patient suffers from a cardiac arrest, hypothermia, or serious post-op complications. Also, there can be an embolectomy done actually by opening the chest and removing the embolus. Of course, this is a last-ditch choice. So preventing pulmonary embolism, first, anticoagulants. The patient has, for instance, DVT. They need to be on heparin or on warfarin, also known as Coumadin. Coumadin is the drug of choice because it's taken orally. Other methods for preventing a PE include compression stockings to prevent venous pooling, pneumatic compression of the veins, and also, that's the best choice of all, if it can be done, is physical activity. Walking around is enough. Air travel produces a high risk. The longer the flight, the greater the risk there is for a pulmonary embolism because they're sitting down. Preventing the problems associated with air travel include the person using fluids, drinking lots of fluids. However, they can't be alcohol. Avoid alcohol and smoking. It's best to wear loose clothing. There can be used. Elastic support stockings are very good. Also avoid leg crossing. This is something I catch myself. I know damn well I should not cross my legs, but I do it when I'm just sitting watching TV and I make a mental note to uncross. Also, again, prevention, physical activity. That's why some patients on long air flights, they need to get up and walk around a couple of times. Another preventative is vena cava filter or Greenfield filter. This is important, especially for patients with contraindications to anticoagulation. Greenfield circuit is inserted percutaneously. It is an outpatient procedure. The patient does not be admitted to the hospital. And it's what's great is now there are temporary retrievable filters available. Okay, that's it with pulmonary thromboembolism. What we're going to do now is just look at pulmonary hypertension. What is it? It's an elevated pulmonary artery pressure. Normal pulmonary artery pressure is 13 millimeters, the mean. If the mean is greater than 25, then there is pulmonary arterial hypertension. It is classified by the World Health Organization into five different groups. First is group one. Group one are those that are caused by idiopathic and unknown etiology. Familial, persistent pulmonary hypertension of the newborn or PPHN. Group one is also associated with portal hypertension, collagen disease, HIV infection, and toxins such as there was a diet drug years ago called fen-phen, and it caused pulmonary hypertension. People died, and there was lots of litigation over that. Big case. Then there's group two. This is pulmonary hypertension associated with left heart disease, left-sided atrial or ventricular disease, left-sided valvular disease. Then group three, pulmonary hypertension associated with lung diseases and or hypoxemia. These include COPD, interstitial lung disease, sleep disordered breathing, and chronic high altitude exposure. Group four, pulmonary hypertension due to chronic thrombotic and or embolic disease. And group five is a miscellaneous category. This includes patients with sarcoidosis, histiocytosis, and also compression of the pulmonary vessels by neoplasms. Okay, acute PH can occur due to cardiac interventions. And this is because we get reperfusion injury, which is return of blood flow to formerly ischemic myocardium. So what we get is a stun, or we have a stunned myocardium. Prolonged is defined as prolonged post-ischemic dysfunction of viable tissue that has been salvaged by reperfusion. And this releases all kinds of nasty chemicals that cause pulmonary hypertension. Reperfusion injury occurs after coronary thrombolysis, percutaneous coronary interventions, coronary artery bypass, and also heart transplantation. This is something also to watch for after any heart surgical procedure. There are also functional classifications of PH. First, class 1, no limitation of physical activity, ordinary physical activity. Class 2, slight limitation of physical activity where the patient is comfortable at rest, but ordinary physical activity causes dyspnea, fatigue, or chest pain. Class 3, marked limitation of physical activity. Patient may be comfortable at rest, but minimal activity causes dyspnea, fatigue, chest pain. Class 4 is the inability for physical activity without symptoms. Can't do squat, even squat. They'll have right heart failure, dyspnea, and/or fatigue at rest, and discomfort with any physical activity. So the manifestations of PAH. First, increased pulmonary artery pressure. And this can be diagnosed with an echocardiograph, which is non-invasive, or with a right heart catheterization, which is definitive, of course, much more invasive and more likely to produce adverse outcomes. We'll also have right ventricular hypertrophy, and this can even be seen on a chest radiograph. The patient will be severely hypoxemia, especially in the presence of, if they have an anatomic shunt, such as an atrial septal defect. They will be cyanotic. So the other manifestations: dyspnea, fatigue, syncope, chest pressure, pain, edema, pedal edema, ascites, edema in the abdomen, tachycardia, palpitations. PAH can mimic asthma, especially in young patients. So what do we do about it? Well, there are lots of things to do. First is drugs. General management includes oxygen, which reverses the hypoxemic vasoconstriction, anticoagulants, diuretic, potassium, inotropic agents to increase ventricular dysfunction, contraction, and function. And there is a management algorithm, and I just did not include it on here, but there is an algorithm. Okay, medications are used, include first, the first line is calcium channel blocker, such as amlodipine, nifedipine, diltiazem, and cardizem. Then there are the endothelin antagonists, and this one, bosentan or Tracleer. This is a very good drug. I looked more recently into the research on this. As of 2022, it is administered orally, which is a big deal. It will cause birth defects. It does have a potential for hepatotoxicity, damage to the liver. However, there is even evidence. One patient overdosed on a very large dose of bosentan and had no sequelae to the overdose. They had very moderate side effects of this overdose, but they came out of it okay, with no long-term effects. Then there are the phosphodiesterase inhibitors. These include Viagra and Cialis and Levitra. And I do remember before I was aware of what was going on. I remember a female patient in the intensive unit. I overheard that she was getting Viagra. And what the hell was that all about? Well, it was for pulmonary hypertension. Another one is milrinone, which is also known as Primacor. Milrinone is nebulized for pulmonary arterial hypertension that is due to reperfusion injury. I worked in a cardiac ICU where lots of our patients post-op got nebulized Primacor to prevent PAH. Then there is nitric oxide gas. It selectively dilates the pulmonary vessels because rapidly taken up by the hemoglobin and neutralized. It does decrease pulmonary vascular resistance. It improves VQ matching by increasing blood flow to the ventilated alveoli. Sounds great, doesn't it? Disadvantages of nitric oxide. It requires an inovent, additional equipment. includes, it requires additional training. And also, if the NO is disrupted, there will be rebound hypertension. NO, very costly. More importantly, even better, there are prostacyclins. These are endogenous vasodilators. We always have them in our bodies at different levels. There are also the prostaglandin I2 analogs, which are synthetic, and they have used for non-acute indications are WHO group 1, NYH class 3 to 4 severity, and failure of other medications. Among these are iloprost or Venovis, which is a prostaglandin I2 analog. It is much more potent than nitric oxide. Its effective duration is 120 minutes. It is given by aerosol 2.5 to 5 micrograms 6 to 9 times daily. The unit doses are available are 2.5 or 5 micrograms. Does require a specific nebulizer. Then there is Flolan. Flolan is a very short-acting prostaglandin PGI2. It is still less expensive than INO, nitric oxide. However, the duration of action is only 3 to 5 minutes. It can be delivered by continuous infusion for acute or non-acute care, or by continuous aerosol, which gets us involved. This is an acute care alternative to nitric oxide, a much better alternative to nitric oxide. It is delivered by infusion. It has the same indications as Venovis for non-acute setting. Cost is greater than $100,000 a year. In a home care setting, the patient must have an infusion pump. Okay, as indicated for severe PAH refractory to standard therapy, such as reperfusion injury, portal pulmonary hypertension, independent or single lung ventilation, ARDS, PPHN, right ventricular failure, or septic shock. Precautions with Flolan. Interruption of delivery can result in rebound of the pH and death. May cause systemic hypotension, but is unlikely. May cause hemorrhage. Flolan is photosensitive, so it must be shielded from light. That's no big deal. Foil. Then there is treprostinil remodeling. This is formulated for IV or subcutaneous injection. There's a 4-hour duration of action. Pilot studies of treprostinil found sustained vasodilation greater than 3 hours with dosage delivered in a single breath. Additional study is required for the aerosol route.